Welcome to Graceland Diabetes Foundation, an international diabetes educators, reaching out to people in United Kingdom, Africa and the world at large. In our previous episode, we talked about insulin as it affects type 1 and type 2 diabetes. In today's episode, we shall be discussing on how to manage diabetes mellitus. Our instructor for today is Pat Carwin, an international coordinator, Graceland Diabetes Foundation. You are welcome, Ma.
Thank you. I am pleased to be here today. In continuation of the topic on diabetes, I shall be talking on how to manage diabetes mellitus.
How do one manage diabetes, since you said previously that diabetes isn't a death sentence?
In the management of diabetes mellitus, the major components of the treatment of diabetes are diet and exercise, oral hypoglycemic therapy, and insulin therapy.
What is diet?
Diet is a basic part of management in every case. Treatment cannot be effective unless adequate attention is given to ensuring appropriate nutrition. Dietary treatment should aim at ensuring weight control, providing nutritional requirements, to allowing good glycemic control, with blood glucose levels as close to normal as possible, correcting any associated blood lipid abnormalities.
What about exercise?
Physical activity promotes weight reduction and improves insulin sensitivity, thus lowering blood glucose levels. Together with dietary treatment, a program of regular physical activity and exercise should be considered for each person. Such a program must be tailored to the individual's health status and fitness.
That means not all types of exercise are good for a diabetes patient.
Yes. People should, however, be educated about the potential risk of hypoglycemia and how to avoid it. Next, is oral anti-diabetic agents.
What are the types of oral anti-diabetes agents?
There are currently 4 classes of oral anti-diabetic agents: biguanides, insulin secretagogues, sulfonylureas, insulin secretagogues, non-sulfonylureas, glucosidase inhibitors, and thiazolidinediones. TZDs. Next is oral agent monotherapy. If glycemic control is not achieved, HbA1c greater than 6.5% and or FPG greater than 7.0 mmol/L or RPG greater than 11 mmol/L with lifestyle modification within 1 to 3 months, oral anti-diabetic agent should be initiated.
Wow.
In the presence of marked hyperglycemia in newly diagnosed symptomatic type 2 diabetes, oral antidiabetic agents can be considered at the outset, together with lifestyle modification. As first-line therapy, obese type 2 patients should consider use of Metformin, acarbose or TZD. Non-obese type 2 patients should consider the use of Metformin or insulin secretagogues.
What are Metformin drugs?
Metformin is the drug of choice in overweight, obese patients. TZDs and acarbose are acceptable alternatives in those who are intolerant to Metformin.
So what happened if it fails?
If monotherapy fails, a combination of TZDs, acarbose and Metformin is recommended. If targets are still not achieved, insulin secretagogues may be added.
This is insightful.
You are welcome. Please note that combination oral agents is indicated in newly diagnosed symptomatic patients. Patients who are not reaching targets after 3 months on monotherapy.
What other ways can one manage diabetes mellitus?
Combination oral agent and insulin. If targets have not been reached after optimal dose of combination therapy for 3 months, consider adding intermediate-acting, long-acting insulin, BIDS.
How effective is this method?
Combination of insulin plus oral anti-diabetic agents BIDS has been shown to improve glycemic control in those not achieving target, despite maximal combination oral anti-diabetic agents. Combining insulin and the following oral anti-diabetic agents has been shown to be effective in people with type 2 diabetes: biguanide, Metformin, insulin secretagogues, sulfonylureas, insulin sensitizers, TZDs. The combination of a 720+ insulin is not an approved indication. Glucosidase inhibitor, acarbose. It's safe to say insulin dose can be increased until target FPG is achieved.
Does insulin have any usefulness in managing diabetes mellitus?
Yes, it does. It has a short-term and a long-term usage.
Alright. Kindly tell us about the short-term use.
Short-term use in acute illness, surgery, stress and emergencies, pregnancy and breastfeeding. Insulin may be used as initial therapy, in type 2 diabetes in marked hyperglycemia, severe metabolic decompensation, diabetic ketoacidosis, hyperosmolar non-ketotic coma, lactic acidosis, severe hypertriglyceridemia.
I am relieved by this information. What about the long-term usage?
On long-term usage, if targets have not been reached, after optimal dose of combination therapy or BIDS, consider change to multi-dose insulin therapy. When initiating this, insulin secretagogues should be stopped, and insulin sensitizers e.g. Metformin or TZDs, can be continued.
In the absence of an expert, what should a diabetes patient do?
Patients should be educated to practice self-care. This will allow the patient to assume responsibility and control of his or her own diabetes.
This is wonderful. So what are the self-care methods?
The self-care should include blood glucose monitoring, body weight monitoring, foot care, personal hygiene, healthy lifestyle and diet, or physical activity.
Kudos to Graceland Diabetes Foundation.
Let me add this. Identify targets for control, stopping smoking, and carrying diabetic identity card. All self-care to managing diabetes mellitus.
Wow, you have done a finished job to this topic, Ma. My regards to Graceland Diabetes Foundation and the team worldwide.
It's my pleasure.
That will be all for today. We shall discuss more in our upcoming videos. Thank you for watching.